This week on the Back Table Podcast.
I personally think it's almost impossible to be a disease expert unless you narrow down, right? If you are doing arterial disease, venous disease, fibroids, prostates, cancer, liver cancer, lung cancer, dialysis, neuro, how can
You're just half-assing everything then.
Exactly.
I'm sorry, you
exactly.
are. It's almost impossible unless you're Superman.
I totally agree.
You can't do all of that. I'm not even talking a 10 out of 10 quality. You can't even do that at a 9 out of 10 or even an 8 out of 10.
And how do you know the literature, right? How do you go to the multidisciplinary meetings and understand what that patient care algorithm should look like?
Welcome to Back Table Tumor Board, your source for the latest on multidisciplinary cancer care.
Well, welcome guys. Have a nice group of you guys here with various different practice patterns, and we're here to talk about how that came to be. So I don't know if you guys want to go around in a circle and tell us who you are and what your practice is like now.
My name is Siddarth Padia. I'm an interventional radiologist at UCLA. I've been out for 15 years and at UCLA for the last 8. So I would say the majority of my practice is interventional oncology, predominantly liver and kidney.
Tyler Sandow, interventional radiologist at Ochsner Health in New Orleans. Similar to Sid, the majority of my practice is probably interventional oncology. The majority of that focuses in the liver. Been out for about 7 years, and been in New Orleans that entire time.
Perfect. I'm Zach Berman. I'm an interventional radiologist at UC San Diego. I'm also predominantly liver cancer care. I've been out about 5 years.
I'm Kevin Burns. I'm a private practice interventional radiologist in Orange County, California. Been out 6 years as well. I would say private practice, we're still probably mostly other IR, but maybe 50% of my practice is IO now.
And I'm Kavi Krishnasamy. I'm at UAB in Birmingham, Alabama. I'm about 11 to 12 years out now, and I think about 75% of my practice is IO. The other 25% is pain, trained in DC years ago.
Great. Does anyone want to share how they got interested in IO, how they started, or kind of how they ended up where they are today?
So I was actually very heavy vascular trained. And so when I came out of fellowship, I'd done a bunch of aortas, a bunch of legs, and a lot of carotid, but I'd always wanted to stay academic. And the only academic job I could find in the location that I wanted to be in was a very heavy IO practice. So I had to switch, and I kind of learned on the fly, and that's how it happened for me. And then I've just never looked back.
I think for me, I was just in the right place at the right time. I didn't necessarily, coming out of fellowship, even though I did my fellowship at a very heavy IO practice, my goal was just to do complex and high-end interventional radiology. And when I entered my first job, the unmet at that time in 2009 and 2010, vascular surgery had taken over most of peripheral arterial disease. Venous disease had not really been developed at that time, 15 years ago, like it is today. And so there was this huge unmet need for liver oncology at the time. And it was a time of where I think most institutions were doing chemoembolization, right? So it was kind of a nice opportunity to start a practice at 15 years ago because it was wide open at the time.
Similar to you, I wanted to do very high-end IR. And in my residency, we had an incredible neurointerventional team. And I actually was really interested in stroke work when I was out there, and I wanted to build this stroke database to basically kind of set myself up for some research success down the road. Well, my program director, who was the big stroke guy, wound up picking one of my co-residents to choose to build this project. So to put things in, back in his face, it was kind of like a gotcha moment. I built a HCC database in liver transplant, which is now morphed into a much bigger monster than we could have ever imagined. So mine started because I just wanted to do high-end IR, and we had an unmet need in terms of looking at our interventional oncology outcomes. And since then, it's allowed us to track and kind of see how we trend with, everyone else and all the outcomes that come out.
Yeah, I think I've always been interested in oncology. I went to an oncology-heavy fellowship program as well. When I came out of training, went into kind of a void where, interventional oncology was ports and biopsies. So there was a big space to fill. And so I think a lot of the IO procedures we do are very elegant. So I think they are the high-end things, and you're replacing surgery for some patients. And so you can help a lot of people doing IO, especially in, if you go to an area that's not a big academic center, you may go somewhere and they don't have, the oncologist doesn't know what Y90 is. Like, that's real across the country. So I think you can make a big difference doing interventional oncology.
Yeah, my story was similar to yours, where I was hired, actually. If you guys have my offer letter still, it's really funny. It says you're going to be doing spine and like musculoskeletal conditions, because we had nobody in our group doing it at the time. And then COVID happened, and we had some, staff turnover from COVID. And all of a sudden, we had a huge gap in the liver oncology space. And, as a junior attending, we can get into this a little bit too, especially in a bigger established group. You're kind of told a little bit what you're doing. And I'm sure, you experienced that. And I don't know if you guys had the same experience, but it was kind of like, okay, like now you're going to do more of the liver oncology stuff because we need someone to do those cases. And much like all of you, and I think a lot of people out there, like we just want to do complex IR. And it was interesting how much my career changed because of that. Again, I would not turn back like you guys mentioned at all. Did you guys feel any of that pressure? Especially I'd like to see the private practice perspective of being kind of told what you were having to do. How did you navigate that?
I think I'm in a unique private practice situation, so I'm not part of a very large group. So we kind of do what we want, I guess. So, there's in private practice, this can be a different discussion. There's a lot of different models that you can be in. So if you're in a model where you're kind of in charge of your own self, you can direct what you want to do. Obviously, you need to service the hospital. That's your primary goal. So IR in a private practice, you're a service industry, right? You're like anesthesia, you're like pathology, you're like the ER, where the other doctors are expecting you to do dialysis catheters and all this other stuff you want to do is great. But the reason they want you in the hospital is to do all this basic stuff to help their patients. So you do have to balance both of those things, especially if you're trying to like stretch yourself very thin. You may not be able to devote enough time to interventional oncology. So it's something to kind of watch out for in that sense. So it's really nice to have other partners in your group that share a similar vision.
Yeah, I think it's a great point. I think for me, as I've evolved over the years, I've steered away from jobs where I didn't feel like I was going to professionally be satisfied. So if I interviewed for a job and they had enough, liver cancer people, if you will, that's probably not a job that I was going to take. And that's okay. You want to know those things go up front and then not join a group and then just be kind of, on the outside looking in. So I always appreciate that kind of honesty and then I'll find the job that kind of suits me.
Yeah, mine was a little different. My most recent job, I started when I was already 7 or 8 years out of practice, and at my previous one at University of Washington, where we built this massive interventional oncology practice, mostly because we were capturing every single patient in the Pacific Northwest. When I came down to UCLA, there was basically an immediate attempt to push me out of oncology from, I would say, day one. And so it was an uphill battle for me. The way it was structured, the way oncology was structured, especially liver, was very different than, I would say, not only my previous job, but 99% of institutions across the United States. And so it was a challenge. I would say the first 2 years were super tough. I had a lot of downtime. I was kind of bored a lot especially in the first year because I had no work. But you just gradually chip away, right? And you start to build relationships. You try to find areas of unmet need. And we basically just grew that over the time. We're still trying to grow that. We still have challenges. But it was challenging in the beginning, and I was not welcome in the very beginning with especially to oncology.
Well, no one puts baby in the corner, right? Yeah.
There were honestly, Tyler, there were times where I wanted to throw in the towel. There were several times where I was like, okay, this is just not for me. This is not a good fit. I'm going to start looking elsewhere. But you guys all know it's really hard to move, right? It's a huge effort. My wife has to look for a new job and so on. So it's not that easy to move. And so it takes a lot for you to like just pick up and leave again. But despite that, I had considered it several times in the first 2 years because I was really unhappy. And then all of a sudden, at around 2 years, things start to click. I start to build like friendships and relationships with surgeons and oncologists, and things start to go, I think, the right way. We hired a couple of junior guys who were absolutely amazing in our group. And so now things are 100 times better than they were when I started.
I think you brought up a great point right there. I'll say when I started, I left residency going to fellowship with the intent to come back to where I did my residency. It was basically like I took a sabbatical for a year, hoping that my job would be there. I did meet a lot of internal challenges about how my practice would be started. But I will say what I've noticed amongst people that are fresh out, both at my institution as well as institutions elsewhere when they call me and they talk, that year 2 moment is where things change. And it's about making sure you continue to foster those relationships that you highlighted. And it tends to come because there's a lot of skepticism being the new guy, right? Even though I think it's great for people to hear this because you are a well-established name in IO. But you're going to meet skepticism outside of the IR field. Surgeons are going to want to know that you can hold your own, that you can deliver on the results. They want reproducibility. So they're always going to wonder about your skill set. And I think that fighting through that, recognizing that that's going to happen wherever you go and fighting through it, that year 2 mark, from what it seemed like for me, as well as other people I've encountered and what you just said, you wind up seeing people kind of break through the wall. And then you start to see yourself ascending.
Not only that, you go to a new place and it's almost impossible, no matter what your years of experience are, to walk into a new place and say, this is how it's going to be done, right? The guys who are already there, whether it's the IRs, the surgeons, the oncologists, they don't want to hear that. You're basically telling them that, what, we've been doing it wrong this whole time? Like, is that what you're telling us, new guy? Like, that does not go over well. And I tried that. It didn't go over well on day one. It really did not go over well. They're like, who's this guy? Get out of here, right? So what you have to do is just slowly convince them, right? Like piece by piece, and just show them in your own subtle way. And it will not be successful on month 1. It won't even be successful on month 6. It will literally take, you said it, it'll take up to 2 years to do that.
Yeah, convince people with the results, right?
Yeah.
So especially if you're bringing a new procedure in, say you go to a private practice and you're just like, I'm going to do lung cryoablation, and you talk about that at your thoracic tumor board, and no one's like, we don't do that here. So like you can't, I wouldn't take a high risk patient at the beginning. You need to have really good wins early to show referring providers that you have good results that are safe. I think that's one of the main things too.
One of the things, even in addition to the results, was the availability. So the first thing I did, I was like, okay, when I started at UCLA, HCC was a little bit saturated, but I found that we have this huge ophthalmology center with a ton of patients with uveal melanoma. I reached out to our medical oncologists who treat uveal melanoma. I was like, hey, look, I'll get a coffee with you guys. And they agreed. There's 2 melanoma oncologists. They sat down with me and they unloaded on me for like 20 minutes. And they told me everything that's wrong with the IR section. And we send a patient to you guys, right? You always get the you guys. I had been there for 1 week, right? So I had no idea what they were even referring to. And we never hear back. And it'll be 4 months by the time they get a Y90. And by that time, they've progressed. And I haven't even seen the patient in that time. So it's just sending them into this vortex, this black hole. Okay, so that actually, I'm like, okay, you know what? We can fix that, right? So then I spent the next 3 months diving into the approval appointment process, which is extraordinarily painful, because that's not, as physicians, we're not really trained to know how to do that. And I found all these inefficiencies that we were doing when we were scheduling patients from the time we get a referral to the time they get on the table, right? There were like 4 or 5 delays that were completely unnecessary. So we just whittled away at it, right? And instead of a 3-month turnaround time, we changed it down to about a 10-day turnaround time. And then I would just shoot them an email. I don't call them, page them in the middle of the day because I know they're seeing 20 patients in clinic. I just shoot them an email saying, hey, everything's on time. We're getting them on track. We should have them for, let's say they're getting a radioembolization. They'll get a mapping this week. They'll get treatment next week. I'll get an MRI in 1 month, right? And so within 3 months, we changed the process entirely. And that really won over the oncologists for uveal melanoma. And so then we did that for neuroendocrine tumors. We did that for breast cancer, et cetera.
I think that's a great point. And we've run into that too. I think 2 things that were highlighted. The first one is the time, right? It takes a long time to gain that trust. Remember when I started first going to tumor boards, it took 6 months before they even acknowledged I was in the room. I'd be, at the room sitting with them. They would show, a mass and they'd be like, oh, we should biopsy it. I guess we'll just go see if IR can do it. And I'm like, literally sitting next to them at the table. I'm like, we can do it. I'm here. And so it takes time to get that. And the second thing is, you really do want to expedite it, but you have to be careful to not just expedite the Y90s, the ablations. Getting a port in fast.
Absolutely.
For an oncologist is super important, and they'll respect you, right? They're not going to ask you for every port to be in within the same week, but the oncologist knows this is a high-risk pancreatic cancer. I need to get a port for chemo as soon as possible. If you can get that within a week, and you can almost always squeeze a port in somewhere, you can really gain respect from that.
Same with the biopsy as well, right?
Well, I was going to say this. Sometimes if you're going to do a biopsy and you recognize that this is a malignant patient, putting in a port at the time of biopsy, assuming you can get insurance approval and those things work, you will save them a headache. And in terms of relationship building, just like meeting with people and understanding their needs, making their life easy goes an incredibly long way to fostering a relationship where people are like, that person delivers for me, right? Like if you want to get past a 2-year mark for getting on the way to success, the more you make a referring physician's life easier, the more likely they are to start trusting you and accepting you and sending you stuff. it becomes less of an order and more of a discussion or a consult. And then optimizing those processes has led to an entirely different approach to IR at Ochsner for us as well.
And I think going back to the communication, that's important as well. Like, for us, every biopsy, every mapping, every ablation, every treatment, there's a call to the I'm not sending the note to the referring. I'm calling them like, this is what we did. Cytopath was in the room for the biopsy, good samples. I think you'll get a great genomic analysis. We'll keep you updated when we see the results back, things like that. I think those things go a long way as well. And then to your point, I still think even in academics, there's a lot of misperceptions of what we do and what we offer, right? The number of times that I run into a close oncology colleague and he or she tells me, well, I thought you needed all chemo stopped. And it's been off for like 8 weeks. I'm like, okay, let's readdress that, right? And let's figure out how we can better sync the two therapies and optimize how we treat this patient. And so I think that constant communication is super, super valuable.
I'll say for oncologists too, what impresses them is maybe not your SPECT CT from your Y90, but like a really complicated biopsy that you did for them. Like I was at a tumor board listening and the oncologist was like, I can't believe you did that biopsy. That was crazy. You got the sample, we got the diagnosis. And I was, in my mind, this is a very simple biopsy. The needle just happens to be right next to a bunch of critical things, but I'm pointing in the safe direction. And that impressed them more than anything I'd ever done. But you do a really good biopsy for an oncologist and they text you about every case, right? They're like, what can you do for this patient? So I think that's really important, and especially in private practice.
Because you become not the Y90 person or the ablation person, you become the helping cancer journey person.
I would say in private practice too, it helps for us. Like we're the problem solvers for all these oncologists. Like they'll say this patient has pain. They're not telling you they need a bone, this T7 cryoablation for this. They're saying this patient has pain. Can you see them figure it out? And so you were doing a lot of pain. I've developed a lot of pain practice. I think that's, in private practice, that's really important. We work with our palliative care team, which I think we could discuss, like getting relationships with all these other teams in the hospital. So I do a lot of palliative interventions, which I think is very helpful because that was maybe something, especially in a big academic center, you probably have this, but if you're not, you're offering a service that was not offered to these oncologists and you're helping the patient. That's the main thing. That patient's going back to the office and saying, my pain is gone, or I'm way better. Thank you for sending me over to him.
Have you had a similar experience with that?
Absolutely. And just the availability. I mean, I think Sid mentioned that, just the availability. And I know I'm going to say this, I'm on one end of the spectrum when I say this, but my phone is on 24/7, whether I'm in this country or not in this country. I'm always available. And I think that goes a long way as well. I think anything you can help and do for the patient, getting him in pain palliative procedures or referring him to one of my partners for, a filter removal, just being available and then directing the patient's care goes a significantly long way. And it's a paradigm shift from how IRs used to practice, right? And that's what is so eye-opening for some of our referrers is that 10 years ago, IRs didn't practice this way. And now we were just a completely different specialty.
Yeah, every referring physician that I personally work with has my cell phone number. Yeah. And they are welcome to call me or text me anytime.
And some patients probably have our cell phone numbers too. I mean, I don't give my cell phone out to every patient, but there's select patients that, most patients do not abuse your contact information. I would, at least that's my experience.
It just takes one though.
Yeah. But I would say there's certain patients that, you may need to have a more close eye on. It's just easier to text them. That way they have a good experience with their whole care delivery process.
Best thing that happened to me was we brought the people that would be communicating with me right now to this creator weekend. So they were asking me questions while I was here. So my phone wasn't going crazy. But I share the same sentiment. Our phone's on all the time. That we have people in our group whose phones aren't on all the time. And there's a couple of us that have our phones on all the time. And I got to always give Juan Himon as a shout out because he's kind of the guy that set that up for us. But he answers the phone nonstop. You can call this guy in the middle of the night. You can call him while he's out of the country. He will respond. And when your leader is the one showing you that, you're going to follow that model. And so that's what I do the same way.
That is a great similarity between private practice and academics. I think it would be great to discuss maybe some differences between academics and private practice for someone who may be looking to build a practice and what they foresee. So I think a great place to start would be in private practice. I'm assuming you have an outpatient clinic. Was that hard to get set up, et cetera?
Exquisitely hard. In fact, we're mostly a telemedicine clinic. I would say 100% telemedicine clinic now. I think so if you're if you're trying to start this, just start a telemedicine clinic because you don't need any staff really to run that. It's way more efficient also. And most of your patients, you're examining their imaging, not the patient. There's certain patients that, yes, if you're doing PAD, it's probably not a good place for a virtual clinic, but interventional oncology, it's great. You're looking at the images, You can screen share, depending on how you're doing it, screen share with the patient, show them the images, talk to them. You can look at them. Okay, they're not laying in a bed, like on their deathbed. Like that's usually gets the exam you need to make sure that they're a candidate for a procedure. So that's much more efficient. Physical clinic is still challenging. I'm about there, and I've been working on this for 4 years. So depending on how you work you have to sell that this business is a business. If you can break even on it, I think that's the goal. But if you can have a virtual clinic, depending on how you schedule, I'll just see clinic patients between cases. The patient doesn't know where you are. So I think that's a really easy way. You can just add on 4 patients every day, especially if the problem is, so we'll schedule them. Your clinic's at 9:02, they have not been called. They are calling my scheduler saying, when is my call? So if you can make a virtual clinic and say you're going to get called between 9 and 10, and then you can work that into your daily schedule. And I use the Doximity app. We can talk about, that's what we use. You have it on your phone, your computer. You can call them from anywhere. It doesn't give them your phone number. You can do video call, text, whatever, and you just talk to the patient and document, and there's your clinic.
I like that Doximity as well because they also have translators.
I haven't used that yet. Okay.
I have a lot of patients who don't speak English as their first language, so it's super helpful. I think clinic space in academics is also a problem. I think that's underlooked a lot. I struggle to get clinic space because I'm not doing procedures. I obviously have a clinic, but if I ever wanted to expand it because my practice has been growing, when I'm not doing ports or biopsies or whatever, I'm not making RVUs. So have you guys run into any issues with expanding a clinic or making it grow?
We haven't. I mean, we actually have my partners who were there long before me saw that clinic model probably 20 years ago before I even graduated. So when I came in, they asked me how much clinic I wanted. I started out with a half day a week. It gradually, after about 2 years, went to a full day a week. Now I'm at 1.5 days a week. We do it hybrid. We do it hybrid, tele plus in person. So we gave the patients the option. Well, actually, for oncology patients, we give them the option. For patients where I'm doing joints, which is my other big part of my practice, I do those in person. But let's say the oncology patients, we give them the option. We call them and say, do you want it in person or do you want it tele? I would say the vast majority ask for tele, mostly because the parking at UCLA is exorbitantly expensive and traffic is terrible. So it costs them $30 and a whole day of driving in to see me. And so that, we haven't had really a shortage of that. We have seen, I don't have the specifics on financials, but we are certainly in the black in terms of a positive financial margin in strictly seeing our clinic patients via telemedicine or in person. So it has not been a money loser for us by any means.
And I'll say, as I've been more similar, so I started with pretty much no clinic. I'm basically up to a day and a half now. But the procedure volume has expanded significantly from that. So it's kind of hard to associate those together to an administrator possibly, because on that day, you didn't generate as much work. But you can be like, okay, well, now my procedure volume on this procedure increased 50%. It's because I have a clinic. So there's a lot of, and you talked about 2 years into the process, this takes a while to develop. So your clinic is going to show results in years, potentially, because that
and it's actually hard now. Now that I have 1.5 days of clinic, that means that's 1.5 days where I'm not doing procedures. So if I'm seeing, last week I saw about 35 patients in that 1.5 days, it's now getting harder to fit those few patients where I'm doing the procedures on the remaining 3.5 days of the week. So you have to, I think each one of us, wherever you are, whatever setting you are, you just have to reach that magic balance, right? And you can always tweak it. Hopefully you're in a place where you can tweak it every several months. You can add something, you can take something away, et cetera.
If you see a patient in clinic, are you doing the procedure, or do you tell the patient, we've got 5 people, they all do the same thing, we're going to get you on first available?
It's a great question. And I think right now, I'm the one doing the procedure. It happens to be that my practice, most of the patients have, basically looked me up and said, okay, I want to see this guy. And I will often, especially if I see my schedule that, let's say I'm out of town or I'm super booked. So I may say, look, I may have one of my partners do it. And if they're cool with that, great. If they're not cool with that and they want me to do it, and this is not just me, this is for all my partners, then I will do it. And that, it's possible they may have to wait a little bit longer. That being said, we try to keep our wait times. That's one of the other things about being available. We minimize our wait times down to less than, I would say on the order of a few weeks or less.
I think it's important as we talk about clinic that those clinic visits are RVUs too, right? So it's not to say that you're not making RVUs by having a clinic. You're just probably not generating as many RVUs as you would be doing procedures. And that makes total sense. We started in 2016, 2017, our clinic was basically a closet. and it worked 1 or 2 days a week, and it was staffed by our incredible nurse practitioner who's been with us, since, for almost a decade, over a decade, I think at this point. And we demanded that we're going to do more. We're going to bring more RVUs in, and maybe we only staffed it with APPs at the time. And so, but the APPs can now generate RVUs by hosting that clinic space. So then we got formal space in the actual clinic setup of the hospital. And then we brought in our interventionalists to actually run the clinic. Well, now we're a little bit short-staffed, and so it's our APPs kind of assume the majority of the clinic visits for us. We're hiring if anyone's interested. We have a great practice in New Orleans, but our APPs were the success, and they are covering the number of RVUs they need to justify their salary via our clinic. And so you can staff appropriately. These RVUs from these clinic visits are not insignificant. And I think that's an important thing to recognize as well.
That's a great segue too. You can't be a one-person show. You need a whole support staff helping you. What do you guys see as like the fundamentals if you're trying to establish a clinic, what you need? Do you need a nurse practitioner right off the bat, or?
I think it all depends on the complexity of the work you do. I think an APP is beyond critical. And as you grow more and more, you're going to need more than one. As a group, we have 6 of them, and some of them cover other sites. At our central hospital, we have 4, and we want to put 6 in reality. More than that, you need people to help you navigate your patients. Like I think one of the most critical pieces of the whole thing is having somebody that can contact your patients, get them on the schedule, get them scheduled for their procedure, get them scheduled for their follow-up. That navigating, you have to have schedulers, you have to have navigators, you have to have people that can call and do pre-op appointments, post-op follow-ups. Somebody needs to make sure that your patient's doing okay on day 1 or day 2 or day 7. So there are critical pieces. We have at Ochsner, centrally, we have 4 schedulers, we have a navigator, we have 2 nurses that do pre-op, and then some of the nurses at some of our other satellite hospitals will also do pre-op and scheduling and things like that. So it takes a system, but when you're starting, got to have a navigator, you got to have a nurse, and you got to have an APP, and those things help you grow.
I would say that I agree with you partly. I think honestly, the schedulers are the most important, right? Because they have to understand the importance of, okay, you're doing someone who's urgent versus not urgent. The not urgent can wait, a month or 2 or 3. The urgent ones have to get somehow squeezed into Dr. Sandow's schedule, in between cases. I found that we have nurse practitioners with us at all times at the clinic, which are a huge help. I don't know when you're starting out, let's say you're under budget constraints or you have administration who does not want you in clinic, maybe asking for a PA or an NP right off the bat might not be the greatest because they're going to be more expensive, right? So maybe wait 6 months to a year once you really develop a busy clinic. Because in the beginning, you may have a half day a week and you may see 1 patient every time. And it's going to look like you're basically wasting your time the whole time because you have to start out with something, right? And then after a month or 2, it's going to be 2 patients. And after a month or 2, it's going to be 3 patients. And then maybe then's a time to ask for an APP because this way you can actually justify it.
I think the one thing is the nurse navigator or some sort of navigator type position. I mean, I think for us, our schedulers are scheduling oncology and non-oncology interventions. And so some of that gets lost in the shuffle a little bit. What's urgent, what's not urgent. You can't expect a non-clinical individual to decipher some of that, right? So that's where a navigator type position is super, super, super important. And not just to facilitate the oncologic experience for the patient, but then also the peer-to-peers and the pre-authorizations and the insurance denials and what paperwork is going where. I think that's also super relevant to this conversation.
I think having someone who does your pre-auths, super important. If they're not doing pre-auths right away, it's going to be hard to get an urgent patient in quickly. Or if they're not paying attention, you may end up getting denied on the back end. And that's a really quick way if you're doing expensive procedures for getting that shut down. If the hospital's losing money because you didn't do the pre-authorization correctly, I have no idea what's happening, right? That's not my job. But you need to make sure someone is keeping an eye on the finances to really make sure you're not losing money.
I'll say in private practice, some of that is your job because you may not have as much staff. I mean, my impression is academics has unlimited staff clicking away, getting insurance authorizations on the schedule. And, we're in a 500-bed hospital, so it's still sizable. We have 2 schedulers. Counting paras thoras, we're probably doing between 20 and 30 cases a day. So we're doing a lot of volume. There are schedulers, they have to schedule stuff. We just got our first nurse navigator 2 weeks ago. So it's already made a huge impact because I have somebody I can just message in Epic, text and say, hey, this patient needs this, and then response is done. So like that's very important, especially if you're going into a hospital. You're going to say, I'm going to do all this cool stuff, but my patients need follow-up. And it's hard to convince a hospital that they need to spend this much money on a nurse that's not doing clinical work. So you may have to do the work first and show that you need this. Same sort of thing. We just got a PA for the first time last year. Big help. I want to get another PA already just because they really help build your practice. But you have to build that practice first.
I don't think it's just prior practice. I mean, I do my own appeal letters at this point, and so, that's, I think when you have a well-rounded team, then some of that can come off of our plate. But you're right. Early on, I think it's not unfathomable to have to do it ourselves.
What do you bring to clinic? I think that's also another thing too, is that like if you can bring a lot of things to clinic, you can also have a lot of things not go through clinic. But if you're trying to make sure that you're occupying your clinic volume, biopsies can occupy a lot of clinic volume. And some of those, I can argue, justify a clinic visit, right? So complex biopsies, I think you need to have a realistic discussion that things could go a little haywire. And it's better to say that in a clinic visit than it is 10 minutes before a procedure.
So Tyler, are you mandating that they have a consult beforehand? Are you giving the patient an option?
I think it depends on the situation. And so I think more often than not, we want our biopsies to come through our clinic, because you will be surprised. We have certain sedation guidelines that we need to follow. So if you have sleep apnea or you sleep with a CPAP, that's a mandatory anesthesia need for us. And so what can happen is we may further delay the care of a patient by not having them come through clinic, not recognizing that there are certain things that won't let them get sedation. So rather than, what we try to do is we try to make sure that all those patients, their questions are answered, that there's no surprises on the day of. So we do bring, when we can, now we're talking targeted biopsies through clinic. All of our local regional therapies come through clinic. I'm trying to think of what else we bring. From an oncology perspective, that's typically what comes through.
But then if you do that, how do you have enough clinic spots? Because if we were to start, let's say in our practice, if we were to start bringing everyone who needs let's say a chest port or a biopsy into clinic, we can't survive.
Oh, I wouldn't bring a port through.
Okay, so let's say even a biopsy, we're probably in our system doing about 50 biopsies every single day, about 200 to 300 a week. So if we were to add 200 to 300 consults in a week, we don't have the resources for that. We don't even have the physicians for that. So what we've done is say, look, if a patient really wants to discuss it with us, we're happy to, but that's kind of where, you ask where you draw the line. And our line has been therapeutic procedure, therapy, then we bring them in for a consultation. If it's a diagnostic, such as a biopsy, we've just kind of gone ahead with the old school way of doing IR, fully realizing that maybe a consult's helpful, but we don't have that kind of infrastructure and capacity.
Right. And I think it's all depends on what kind of situation you have, right? Like some people aren't doing 500 biopsies a week. Some are maybe doing 10 a week. And so I think it really is situational dependent. And that's our perspective in our volume. We don't have, how many people live in LA? Like 5 million, 10 million
it's
people.
A lot of people.
We don't have 10 million people that live in LA. We have, less than 1 million people that live in the greater New Orleans area. And so the needs that we're filling are not the same as what you would see in LA.
I think that's a great segue too. We talked about starting your practice, having 1 or 2 or 3 patients in your clinic, but eventually that number is going to grow and grow and grow. How about for you guys deciding when it's time to narrow your practice? When do you just say, because we all come out of fellowship, I want to do everything. I want to do aortas, I want to do tips, I want to do Y90, I want to do all the screw and glues in the pelvis, I want to do everything, right? How do you decide when it's time to narrow your practice?
I think it's easy, and I think most of us are probably guilty of this. I think it's easy earlier in your career to be a little bit more broad because you're not totally sure what you're going to like. And maybe what you did in fellowship is not what you are going to really super passionate about, right? So, but that being said, I personally think it's almost impossible to be a disease expert unless you narrow down, right? If you are doing, arterial disease, venous disease, fibroids, prostates, cancer, liver cancer, lung cancer, dialysis, neuro, how can
You're just half-assing everything then.
Exactly.
I'm sorry, you
exactly.
are. It's almost impossible unless you're Superman.
I totally agree.
You can't do all of that. I'm not even talking a 10 out of 10 quality. You can't even do that at a 9 out of 10 or even an 8 out of 10.
And how do you know the literature, right? How do you go to the multidisciplinary meetings and understand what that patient care algorithm should look like? So, yeah.
I mean, for me, I have no huge burning interest in peripheral atherosclerotic disease. I know, some of the major trials. I couldn't tell you all the small trials. If I get a patient with peripheral arterial disease, let's say a consult lands on my desk, I have some amazing partners who are extraordinarily good at this in terms of using their clinical judgment, technical abilities, and I shift it to them. Patient is way better served by them having to do it. Similarly, even in the oncology realm, I don't do lung ablations. I have partners who do hundreds of lung ablations in a year. So if a patient comes in and insists that I do it, I tell them that I'm not that good at this. Okay, and I have partners who are so good at this that they would be idiotic to have me do their lung ablation. And I make sure that they get to see one of my partners. And the patients are much better served. I'm a lot less stressed out by doing that as well.
I think the converse, though, is well, that works for us in academics in a fair amount of places. I don't know that it works in private practice, right? I mean,
that's what I was about to suggest too. A way that I look at it, and we kind of live in this, like, we're half private practice, half academics world. I will say that when you start to realize that when you are taking on so much, like if you become the portal hypertension guy and you're the IO guy, and then all of a sudden you're the arterial guy and you're the venous guy, when you're taking on so much that you are not able to keep up with your volume as well, it's probably time to share, right? And I think that it's also important to recognize that, like, we have to foster the growth of our entire team. And so and especially the young guys, when I wanted to do everything, I wanted to be the UFI guy, I wanted to be the biliary guy, the IO guy, the TIPS guy, and everything. My partners all let me kind of figure out what I wanted and figure out how to do that. But they were in a position where they kind of had all the volume they could share with me. And now I'm in this spot where I'm like, I get a lot of referrals to do a lot of different things. And I find myself, I think I'm fairly decent. But I think it's an opportunity to let them excel and let them build their name too, right? So I really enjoy Y90. I really enjoy ablations. But if we have guys in our group that want to share in that realm and they want to focus in on that too, great. And we have people that, I think when you find yourself to be too burdened by covering more than one aspect of things, it's time to share with the rest of the group.
That's a great point. And I think we're all senior enough in our career where the value of helping our junior colleagues develop is really, really important. I think that's really understated as well. I love what I do. I can do it all day long. I can keep doing it all night long if I have to, but I don't need to. I don't need to do every case, right? I would rather watch my junior colleagues develop and get to the stage that I'm at earlier than me do everything. And I think that's an understated part of what we do as well.
And I think it's hard to give that up too sometimes, right? If you're the guy who does this and all of a sudden now there's another guy or another girl that does this, it can be a little, depending on, your ego, basically, it can be hard to, Can we give that some stuff? I think the easiest thing is when there's a new service line and you're the person who's in charge of everything, give that to somebody else to start with. Don't even get involved and say thyroid ablation, comes into your practice. This is someone else's service line. If I get a consult, this is the person, let this person develop it. Same sort of thing. If you're the cancer guy and all of a sudden there's they want to do a pulmonary embolism response team, find a different person who is going to take that on because, you get a lot of duties and then everything gets less time.
And I think you'll be surprised at how eager other people are to take that on. Like, we have really seen some incredible leadership out of some of the colleagues that have started and, after me. They have just taken things and run, and they've helped extend service lines in ways that I would have never thought I would have been able to do. And so it's very nice to be able to watch people do a great job too.
There's a huge danger in overtaking and taking on way too much of yourself, because I think most of us who came out of interventional radiology felt what you said, you want to do all these amazing things. And I actually went into IR because there was so much variety, right? Like, it wasn't like a vascular surgeon who's just doing legs or aortas all day long. Like, you may do a prostate and then a fibroid and then a knee embolization and then a radio embolization and then an ablation. And you could do that all in one day. Like, that's amazing, right? And a G-tube removal to cap it all off. But at some point, it gets so much. And then now we're in an era of, like, if you start to really overwork yourself, not one day, but on a consistent basis where you're killing yourself, you may not notice this, but you're going to start taking it out on other people. Mm-hmm. And not just on your own family, but you're going to take it on the nurses, you're going to take it on the techs. And while that behavior may have been acceptable in the 1980s, it is not acceptable in 2024, whether you like it or not. And this is how I've seen people get into a real hot water when they're in the hospital setting, take it out onto their staff because they are overworked. And it happened to me as well several years ago. So that's the one word of caution of just taking on everything. You're going to start pissing people off. And I would really encourage people to keep that in mind, because you're not going to notice it yourself. It'll be your husband or your wife or your boyfriend or girlfriend who notices it, or, your colleagues at work who notice that you're becoming kind of a jerk because you're just killing yourself at work and you have no time or no patience for anybody else.
Well, great. On that note, how do you determine whether to bring a new technology in? Now that we talked about overextending yourself, but at some point we are IR and we're pushing the field forward, right?
And we'd love to bring in new technology.
Yeah,
That's the whole.
right, here we go.
Yeah, that's what we want. That's what we all live for.
Yeah. So how do you balance that? How do you decide want to bring this brand new technology in? Does it come from your referring providers? Does it come from, what are your guys' thoughts on that?
I'll start off. I think we need to be willing to explore new things. I don't know that we necessarily need to jump in at everything, but I think we need to be receptive to listening, and we need to be appropriately skeptical of everything. I don't think we should always just believe that the new technology is the best thing to come. I think there needs to be appropriate skepticism, but willingness to listen and learn. People consider us great because we've always been part of an innovative field. We've always been trying to push. And if we ever get away from that lack of innovation, we're probably going to get bypassed by something else. And so I think you always got to be willing, but on the same token, appropriately skeptical. And also we need to follow outcomes and data. And I think that matters as new things are coming out. I think that all of those things are going to be important because that's what helps us maintain our reputation with referring providers, but also helps us maintain our cowboy-like attitude, which is what got us to where we are.
Well, I think it goes back to the old adage as well, like if you're standing still, you're falling behind, right? And so we have to do some of those things, right? And it is 100% ingrained into all of us, but for me, part of it is also, as a new device or new technologies comes onto the market, what is the gap that it's filling for me? Or how is it optimizing what I'm currently doing that, maybe I didn't think that it could be better, but maybe it's actually doing it better, right? And then kind of going with that idea and then following with the data and making sure that actually holds true as well.
I think that is a perfect place to stop this conversation for today, although I do want to continue it again in the future. So thank you all for joining us today and having a pretty candid discussion. I appreciate it.
Thanks, Zach.
Thank you. Thanks.
Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable_onc. That's _backtable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.